Hello everyone, this is Zubair Khan and you are watching Joravi Nursing online classes. So today's topic is inflammatory disease of the heart. So today we'll discuss about the inflammatory disease of the heart, endocarditis, pericarditis, myocarditis, this everything we will see in this class. So before starting the class, please subscribe my channel if you are new on my channel. Like this video and share to your friends also. So let us start the class. So inflammatory disease of the heart. So what is inflammatory disease of the heart? What are the inflammation of the heart, that is called inflammatory disease. Okay, so what are the types of that? So pericarditis. So inflammation of the pericardium is called pericarditis. It can be a acute and it can be a chronic. So acute and chronic inflammation of the pericardium is called pericarditis. So chronic pericarditis and chronic inflammatory thickening of pericardium constrict the heart, causing compression. So when pericarditis is there, what it will do? It will constrict the heart. It will constrict the heart and causing the compression of the heart. So when pericarditis is occurring, what will be happen in pericarditis? That pericardium will be become a thick. So it will become a thick. So what it will do? It will resultantly do the constriction of the heart. So it will constrict the heart. So constriction of heart will cause the compression of heart. So if compression will be there, what will be there? So compression will be there, the fluid accumulation will be there. Okay, the pericardial sac becomes inflamed. That pericardial sac will be there, that will be inflamed. So that's why we are saying pericardial inflammation. Okay, so pericardial inflammation means pericarditis. So inflammation of pericardial sac also will be there. So pericarditis can result in loss of pericardial elasticity. So when inflammation is there, so the pericardial elasticity will be lost or accumulation fluid within the sac. So the sac is there, so there will be so much accumulation of the fluid accumulation will be there. So if fluid accumulation will be there, so what will be happen? Heart will not able to the contract properly and heart will not able to the filling properly. So there will lead to the decreased cardiac output. So heart failure will be there. So it is resultantly the heart failure and cardiac tamponade may result. Cardiac tamponade means what? When fluid collection in the that pericardial space, so it cannot contract properly and it cannot filling the ventricles properly, so that means heart failure will be there. So that is called cardiac tamponade. Okay, so assessment, what we need to do? So precordial pain in the anterior chest that radiates to the left side. Okay, so in anterior chest we need to assess the pain. So where it will radiate? It will radiate the left side of the neck. So this is right side, this is left side. So it will radiate to left side of the neck and shoulder or back. Okay, so left side, neck, shoulder or back. Okay, so there we need to assess the pain. Pain is grating and is aggravated by breathing. Okay, when we do inspiration, so it will be so much. When breathing is there, inspiration we do, so that time it will be more painful. Or coughing and swallowing, so swallowing will be there and coughing. So when we do cough, so it will be a painful. Okay, pain is worse when in the supine position. Okay, this is very important point here. When patient lies on the supine position, so that time patient will have a more pain in this condition. So to prevent this so much pain, what we need to do? We need to keep the patient whether is Fowler's position or lean forward position. Okay, patient should not be kept in the supine position. This is very important point here. So in pericarditis, pain will be worse in the, so much pain will be there when patient is on supine position. So should not keep the supine position. Pericardial friction rub. Pericardial friction rub, scratchy high pitched sound is heard on the auscultation. When we do the auscultation, so what will be the sound will be there? High pitched sound we can hear, and pericardial friction rub will be there. Produced by the rubbing of the inflamed pericardial layers. So why it is produced? So there will be a rubbing of the pericardial layers. So that pericardial layers are inflamed, so there will be a rubbing in between them, so that's why there will be a sound, so that will be a scratchy sound. Okay, so and high pitched it will be. So on auscultation we can find this. So what are the other assessment we need to? Fevers will be there whenever inflammation is there, so fevers will be there. Fatigue and malaise will be there. Elevated blood vessels count, WBC count will be elevated because any infection inflammation is there, so WBC will be increased. So what are the changes in the ECG? So ECG changes, we can see ST segment elevation will be there, and onset of inflammation, and atrial fibrillation is the common. So whenever this pericarditis is there, so in ECG ST segment elevation will be there. So this is the main finding on the ECG, atrial ST segment elevation, and the more common is atrial fibrillation. So what are the arrhythmias you can see? Atrial fibrillation you can see on the ECG. Okay, so this is the main common ST segment elevation and atrial fibrillation related will to the pericarditis. And signs of right ventricular failure. So whenever pericarditis is there, so right ventricular failure will be there because it will not be able to proper filling. Okay, and proper cardiac output will not be there. Okay, so in clients with the chronic constrictive pericarditis, so why it is not proper filling? Because the heart is very much constrict, so it will not be able to fill properly, so that's why heart failure will be there. Okay, so this is the right ventricular failure will be due to constrict pericarditis. So what are the intervention we need to do? So first we need to assess the nature of pain, how is pain, and place the client in the high polus position. So we should not keep the client in the supine position, he should be always in the high polus position or upright or leaning forward position. Okay, administer the oxygen we need to administer because patient may have a dyspneic condition. Administer analgesics. So analgesics for pain we need to administer NSAIDs and corticosteroids. Okay, so HCP will be prescribed, so corticosteroids or NSAIDs we can give. Auscultate for pericardial friction rubs, so we can administer, so we will hear this sound, that will be a high pitched sound. Okay, check results of blood culture. So blood culture result we can check to identify the causative organisms, why this inflammation is occurring, which organism is responsible for this, so we can check by the laboratory results. Blood culture we can do. Administer antibiotics for bacterial infection. If any bacterial infection is there, we can administer the antibiotics. And administer diuretics, digoxin as prescribed to the client chronic constrictive pericarditis. Then administer the diuretic digoxin as prescribed to the client with chronic constrictive pericarditis. So diuretics we can give, why? Because the fluid collection is there, so we need to increase the diuresis. So diuretics we can just give in chronic constrictive pericarditis, whatever chronic constrictive pericarditis is there, so diuretics and digoxin also we can give. So surgical incision of the pericardium or pericardiectomy may be necessary, so maybe for surgical incision we can do the pericardiectomy. Okay, monitor for signs of cardiac tamponade. So this is the main important for this condition, cardiac tamponade, it is the main complication, so for that we need to assess the signs and symptoms. Notify the SCP signs and symptom of cardiac tamponade is occurring. Okay, myocarditis. So myocarditis, what is that? Inflammation, acute or chronic inflammation of the myocardium as a result of pericarditis. When pericarditis is occurring, it will lead to the myocarditis also, and systematic infection or allergic response. So due to pericarditis or systematic infection is there or allergic response is there, so it will lead to the myocarditis. So what are the assessment we need to do? So we need to do the assessment. Fever we need to check, dyspnea condition is there, tachycardia is there, chest pain, usually chest pain will be there. What will be there? The pericardial friction rub will be there, so that we can hear by the stethoscope, or auscultation we can do. Gallop rhythm is there, murmur sound. Okay, sounds are murmur like fluid passing and obstruction. Pulses alternance and signs of heart failure, this we can check. Okay, so intervention, what we need to do: assist the client to a position of comfort such as sitting and leaning forward. Same condition I told you in pericarditis, there is only 4 position: sitting or leaning forward position we need to provide. Oxygen we need to administer, and NSAIDs, okay, and steroids also we can give to reduce the fever and pain. Then administer the digoxin as prescribed. So digoxin also we can administer. Then administer anti-dysrhythmics as prescribed. So anti-dysrhythmic medication such as lidocaine and all we can prescribe, because mainly it will be, because it will be here, and what will be there, atrial fibrillation will be may occur. So atrial fibrillation may occur, so for that we can provide the anti-dysrhythmic medications, and administer antibiotics to prescribe the treat the causative organism. So whatever causative organism is there, for that we can provide the any antibiotics. Monitor the complications which can include thrombus, heart failure and cardiomyopathy. So complication will be there, what can be there, thrombus formation will be there, heart failure can be there, and cardiomyopathy. So for thrombus formation we need to give the antithrombolytic therapy, and heart failure, so here we are providing the digoxin, so contracts, so proper it can contract the heart. And cardiomyopathy, why it is occurring, for that we any organism is responsible, or what is that, so for that we can give the medication whatever has to be prescribed. Now coming to endocarditis. So endocarditis is the inflammation of the endocardium or inner layer of the heart and valves. So occurs primarily in the client who have a IV drug abusers. So who will be having this? Mainly who is the IV drug users. So mainly it will be there in the IV drug abusers and have had the valve replacement or repair of valves. So IV abuser, IV drug abuser, and who had the valve replacement with the prosthetic materials or have a structural cardiac defects. So in that condition endocarditis will be there. IV drug abuser, valve replacement, or any structural cardiac defects. Okay. Ports of entry of the infective organisms include the oral cavity. So mainly the portal of entry will be the oral cavity, especially in the client has the and a dental procedure in the previous 3 to 6 months. So this is very important point. So for endocarditis, if patient is coming, so we need to ask any oral surgery or any procedure has been done within the 3 to 6 months. So this question we need to ask the client. And any infection, cutaneous, genitourinary, gastrointestinal and systematic, so it can also lead to the portal, it is also a leading cause of portal entry of any organisms to cause the endocarditis. So and surgery or any invasive procedure including IV line placement and all, so it can lead, it can also a causative organism for endocarditis. Now coming to assessment. So what are the assessment we need to do? Fever, anorexia, weight loss can be there, fatigue can be there, and cardiac murmurs. So this is whatever highlight point is, that is very important. So cardiac murmur we can hear, heart failure will be there, embolic complication from the vegetation fragment traveling through the circulation. So embolic coagulation can be there. Okay, renal emboli, pulmonary emboli, that all. Petechiae will be there, and splinter hemorrhage in the nails bud. So in nails bud you can see the splinter hemorrhage. Okay, and the 2 points are there: ossular nodes and Jennewer's lesion. So ossular node, what? Radius and tender lesion on the pads of the fingers. So in fingers there will be a radius and tender lesions will be there on the fingers, hands and toes, that we call the ossular nodes. So it will be seen in the endocarditis. And Genevieve lesions are non-tender hemorrhagic lesion. Okay, so Genevieve lesion is, it will be a non-tender, whereas ossular nodes will be the tender lesion. Okay, so it can be also seen in the finger, toes, nose and ear lobes, and it may be having the splenomegaly, and clubbing of the fingers also can be seen. So what are the intervention we need to do? Provide the adequate bed rest. Okay, so we need to provide the adequate bed rest bed rest balanced with the activity to prevent thrombus formation. So main thing is we need to prevent the thrombus formation and maintain the anti-embolic stocking. Okay, monitor the signs of heart failure, monitor the for splenic emboli, so it will lead to the emboli. So a mainly splenic emboli can be there. Okay, so if a splenic emboli is there, so what will be there? Patient will be having the abdominal pain radiant to the left shoulder and presence of the rebound abdominal tenderness on the palpation. So whenever splenic emboli is there, left side abdominal pain will be there, so it will go to the left side shoulder. Okay, and abdominal tenderness will be there. Monitor for renal emboli, and renal emboli also it can be there as evidenced by flank pain. So whenever renal emboli is there, flank pain will be there. It will lead to the radiate to the groin, and hematuria will be there, and pyuria will be there whenever renal emboli is occurring. Monitor for confusion, so patient may have a confusion, aphasia and dysphasia also, which may indicate of the central nervous system emboli. So this is the indication for central nervous system emboli. Monitor for pulmonary emboli, so pulmonary emboli is also can be there. So for if pulmonary emboli is there, so what is the signs and symptoms? Pleuritic chest pain will be there, dyspnea will be there, and cough will be there. Assess skin and mucous membrane and conjunctiva for petechiae. So for mucous membrane, and we need to assess the skin, mucous membrane, and conjunctiva for any petechiae is there. Okay, assess nail warts. Okay, so for any splenic hemorrhage is there. Assess for ossular nodes, Jennever lesion, and clubbing of fingers, and evaluate the blood culture for what is the causative organ. For that we need to assess and administer antibiotics intravenously as prescribed. Plan and arrange the discharge and providing resource required for the continuing administration of IV antibiotics. So this everything we need to do. And client education, so this is also important. So client education, what we will say, so teach the client maintain the aseptic techniques during intravenous antibiotics and all. Okay, so IV catheter sites for signs and infection, so we should be report to the SCP immediately. Okay, instruct the client record the temperature daily for up to 6 weeks. So daily should be record the temperature up to 6 weeks. Okay, any report is there, so we should inform the SCP. And oral hygiene twice a daily with a soft toothbrush. Why? Because of the risk for hemorrhage, and rinse well with the water and after brushing. Client observe the signs and symptoms for embolic condition and heart failure. So teach the client, we need to teach the client of observation of signs and symptoms of embolic condition and heart failure. Okay, so this everything he need to do, and he need to watch for the skin laceration is there or not, and apply antibiotic ointment as prescribed. Okay, so teach the client cleansing the any skin laceration, so it should be cleansed, and apply the antibiotics ointment on that. So these are the things we need to teach the client. Now coming to cardiac tamponade. So in cardiac tamponade, what is that? A pericardial effusion will be there. So pericardial effusion will be occurring in that. So when the space between the pericardial, parietal and visceral layers of the pericardium fills with the fluid. So whenever fluid is filled in the in between the both layers, so what will be there? There will be a compression. So what will be there? Pericardial effusion place the client at risk for cardiac tamponade. So there will be a compression will be there. So patient's heart cannot pump the blood properly, and it cannot be a fill properly. So that is called cardiac tamponade. Risk for cardiac tamponade, accumulation of fluids in the pericardial cavity. So pericardial cavity, in pericardial cavity, what will be there? Accumulation fluid will be there. Okay, fluid accumulation will be there. And tamponade restricts the ventricular filling and cardiac output. So when it will lead to the ventricular filling, it will decrease. Okay, it will restrict. So if ventricular filling is not there, then cardiac output also drops. So acute cardiac tamponade can occur when a small volume of 20 to 50 ml of fluid accumulate rapidly in the pericardium. So acute cardiac tamponade can be occur when fluid accumulation is there 20 to 50 ml. So assessment, what are the assessment we need to do? So pulsus paradox, we need to watch for pulsus paradox. What is pulsus paradox? In this condition, that systolic blood pressure or blood that pressure will be decreased if it is going beyond the 10 mmHg. Okay, if it is going drop the less 10 mmHg, it is okay. If it is going beyond the 10 mmHg, less than 10 mmHg, that means like normal blood pressure is 120 110 to 140. If it is going like 800 mmHg is there, okay, so it is also normal. If it is going less than like 10 mmHg is going, okay, so it will be available 90 mmHg. If it is going beyond this, okay, more than 10 mmHg, it will lead to the pulsus paradox. Okay, so everything will be changed. So we need to watch for the BP and pulse and respiration also, okay, in this condition. So what can be there other things? So increased CVP also will be there in this condition. Increased CVP also will be there in jugular venous distension with the clear lungs. Okay, so jugular venous distension will be there. Then distant muffled heart sounds we can hear, decreased cardiac output and narrowing pulse pressure. So pulse pressure will be narrow. Okay, intervention. So what are the intervention we need to do? The client needs to be placed in the critical care units for hemodynamic monitoring. So patient should be kept on the critical care units, that means ICU we need to keep, and administer a fluid intravenously as prescribed to decrease cardiac output, to manage the decreased cardiac output. So cardiac output will be decreased, so for what we need to do? So cardiac output is decreased, so patient will go for hypovolemic shock. Then BP will be fall down. So BP is falling down means, so we need to administer the fluid. So BP is falling down means that is the pulsus paradoxus condition will be there. Prepare the client for the chest X-ray or echocardiography. So we need to prepare the client for the chest X-ray, and okay, or electrocardiography also we can do. Prepare the client for pericardiocentesis with the withdraw pericardial fluid if prescribed. So this also we can do. Monitor the recurrence of tamponade following the pericardiocentesis. Okay, so pericardiocentesis also we can do. If the client experience recurrent tamponade or recurrent effusion, develops adhesion from the chronic pericarditis, so a portion or a pericardium may be removed to allow the adequate ventricular filling and contraction. So if client is experiencing recurrent tamponade, so client is experiencing recurrent tamponade or pericardial effusion, so what we need to do? We can remove a portion of the part. Okay, we can remove the portion or the pericardium may be removed to allow the adequate ventricular filling of and contraction. So that particular part we can remove. Okay, so ventricular filling can be properly and it can contract the properly. So that we say pericardial window. So that portion we can do, pericardial window we can do, or pericardiectomy also we can do. So pericardial window, what we will do, we will put a small incision in that, so that fluid can come out. So we can take the fluid and it will be helpful to ventricular filling and contraction. So that is called pericardial window, or all of the pericardium. So if we are removing the full pericardium, that is pericardiectomy. If we are doing the one portion or a small incision we are doing, that is pericardial window. Okay, so this we can do. Now coming to valvular heart disease. So what are the valvular heart disease? So valvular heart disease is, the valvular heart disease occurs when the heart valves cannot open fully, that means it is stenosis. Okay, cannot open the fully, so that means a stenosis will be there, or closed completely, or it is closed completely means insufficiency or regurgitation is there. Okay, so valvular heart disease prevents the efficient blood flow through the heart. So what are the types of valvular heart disease? So it can be a mitral stenosis can be there, mitral insufficiency, regurgitation will be there, mitral valve prolapse can be there, aortic stenosis and aortic insufficiency. So valvular tissue thickens, narrows, and or valve opening prevent blood from the flowing from the left atrium to left ventricle. So when mitral stenosis is there, so what will be there in mitral stenosis? So that valve will be having the thickens, so blood cannot come from the left atrium to the left ventricles. Okay, so that is the mitral stenosis, because wall will become the thicken or it will be a stenose, so blood cannot come from the left atrium to the left ventricle, so that is called mitral stenosis. If mitral insufficiency is there or regurgitation will be there, valve is incompletely or prevent complete valve closure during systole. So what will be there during systole? That valve cannot be closed completely. Okay, so valve preventing the complete valve closure during systole, so it will be there, valve is incompetent, so that cannot be competent during systole. That means the valve cannot be closer that time. Regurgitation will be there when left ventricle filling, after left ventricle filling, when ventricle is going to the push the blood, ventricle contraction will be there, so that time regurgitation will be there in the left atrium, so that is called mitral insufficiency and regurgitation. And mitral valve prolapse, valve leaflets proceed into the left atrium during systole. So mitral valve prolapse will be there during systole. What will be there? That valve, mitral valve is there, left side, that valve will be the prolapse into the left atrium, so that is called mitral valve prolapse. And aortic stenosis will be there. What is aortic stenosis? Aorta will be become a thick, so vascular tissues and narrowing of the wall opening and prevent blood from the flowing from the left ventricle into the aorta. So aortic stenosis will be there, so that blood cannot enter to the aorta. Okay, so that is called aortic stenosis. And aortic insufficiency, in aortic insufficiency what will be there? In aortic insufficiency, valve is incompetent or prevent the complete valve closure during diastole, so it will be during diastole. So what will be there during diastole? That valve cannot be completely closed. Okay, so that is aortic stenosis or aortic insufficiency. This is aortic stenosis, this is aortic insufficiency. So valve is incompetent, prevent complete valve closure during diastole. Okay, so valve will be the incompetent and it will prevent the complete valve closure. So complete valve closure will not be there during the diastole. So aortic valve will not be closed during the diastole. For aortic disorders and tricuspid disorder, we can see the tables. So repair procedures. So how we can repair the procedures? So valvoplasty we can do. So how we will do balloon valvoplasty? A balloon catheter passed to the femoral vein through the atrial septum to the mitral valve, or through the femoral artery to the aortic valve. So balloon catheter we can put. Okay, if stenosis is there. So balloon is inflated and enlarge the orifice. Okay, so balloon will be inflated and it will increase the diameter of the vessels or valve. Institute the precautions of atrial puncture if appropriate. Okay, so puncture we are going to do, so we need to do precautions appropriately. Monitor for bleeding for catheter insertion. So we are going to insert a catheter, so we need to watch for the bleeding. Okay, monitor the signs of systemic emboli. So emboli can be there, so we need to watch for emboli. And monitor for the signs of regurgitation valve by the monitoring cardiac rhythm, heart sound and cardiac output. So regurgitation can be there, so for that what we need to do? We need to monitor the cardiac rhythm, whether rhythm is normal, normal heart sound is there, or cardiac output is normal. So this we need to watch it. Then what we can do? Mitral annuloplasty. So mitral annuloplasty is tightening and suturing the malfunctioning of the valve annuals to the annulate and greatly reduce regurgitation. So what we can do? Mitral annuloplasty. So we can tighten the mitral valve, so it cannot be a regurgitate. And commissurotomy or valvotomy. So commissurotomy, the procedure accomplished with the cardiopulmonary bypass. So in this what we can do? Cardiopulmonary bypass surgery, open heart surgery we can do. And valvotomy means the valve is visualized, thrombi are removed from the atria, fused leaflets are incised and calcium is deprived from the leaflets, thus widening of the orifice. So overall what we will do, we will open the valve and we will do the widening of the orifice. Okay, we will do the widening. Okay, thrombi will be removed in this surgery. Valve replacement procedure. So valve replacement procedure we can do, so we can replace the valve. So how many types of valve? So there will be first mechanical prosthetic valves. So there will be mechanical prosthetic valves. What we will do, these prosthetic valves are durable. So these valves are prosthetics and durable. So some main important point is there with this valve. Thromboembolism can be a problem with this the following valve replacement of mechanical prosthetic valves. So for that we need to give the lifetime anticoagulant therapy. So when we are going to do the mechanical prosthetic valve, we are going to put, so lifelong anticoagulation therapy is required. Okay, now coming to bioprosthetic valves. So in bioprosthetic valve, what we will do, biological grafts are xenografts, so valves from the other species. So xenograft valve can be there, procan valves from the pig, and bovine from the cow, and homograft from the human cadaver. So we can provide the valves like bioprosthetic. Okay, like xenograft from other species, procan from pig, and bovine from cow, and homograft from human cadavers. We can take the valves. The risk of clotting formation is small, therefore long-term anticoagulation may not be required. So in bioprosthetic, there is no need for long-term anticoagulation therapy. Whereas mechanical valve we are going to put, so long-term anticoagulation therapy is required. Preoperative interventions. So in preoperative intervention, what we need to do, consult with the SCP regarding discontinuing the anticoagulants 72 hours before the surgery. This is very important. So before the surgery we need to withhold the anticoagulant therapy. So for that we need to consult the SCP. And preoperative intervention. So what are the preoperative interventions? So we need to monitor closely for signs of bleeding, monitor cardiac output for signs of heart failure. This we need to do, and administer the digoxin as prescribed to maintain the cardiac output and prevent atrial fibrillation. And client education. So these are the things we need to do: administer the anti-digoxin to prevent the to maintain the cardiac output and prevent the atrial fibrillation. So this is the very important. So first we need to, main important thing is after the procedure, signs of bleeding is very important, then cardiac output and signs of heart failure also. So we need to monitor the VP also, because cardiac output will be less, so VP will be fall down. So teaching, what are the teaching we need to do the clients? So we need to tell the client adequate rest important, fatigue is usual will be there, and anticoagulant therapy is necessary if mechanical prosthetic valve has been inserted. Okay, so this we need to tell. Notify the healthcare provider if bleeding or excessive bruising is occur. This we need to teach the client. Brush teeth twice a daily with soft brush tooth. Okay, soft toothbrush and followed by oral rinse. Heavy lifting more than 10 pound or 4.5 kg is to be avoided. So and exercise caution when in automobile to prevent injury to the external incision. So heavy lifting is contraindicated. Okay, prosthetic valve was inserted, soft audible clicking sound may be heard. So if prosthetic valve is inserted, so only he can hear the soft audible and clicking sound. Okay, clicking sound. So these we need to teach the clients. Now coming to what are the valve disorders, we can see aortic valve. Aortic valve disorders. What are the aortic valve disorders will be there? So aortic stenosis will be there, and aortic insufficiency. So an aortic stenosis, what will be there? Dyspnea will be there, angina, syncope, fatigue, orthopnea, paroxysmal nocturnal dyspnea. Okay, harsh systolic crescendos murmur. In aortic insufficiency, dyspnea, angina, tachycardia, fatigue, orthopnea, paroxysmal nocturnal dyspnea, blowing distinct to diastolic murmur. Okay. So what are the interventions? Refer the sections. So intervention we have already told. Okay. Tricuspid, same only it will be there. Easily fatigue will be there. Asymptomatic in mild situation. Effort intolerance. Complaint of fluttering. Okay. Obstruction venous flow. In this condition, cyanosis will be there, so this is main important, and signs of right ventricular failure will be there, ascites will be there, hepatomegaly will be there, jugular vein distension will be there, clear lung fields will be there, and decreased cardiac output. Okay, tricuspid insufficiency what will be there? Asymptomatic in mild situation, right ventricular heart failure, include ascites, hepatomegaly, and peripheral edema. Pleural effusion can be there, systolic murmur, okay, at the left sternal border and fourth intercostal space. Okay, now coming to pulmonary wall disorder. So pulmonary wall disorder, same dyspnea, fatigue, syncope in pulmonary insufficiency and pulmonary stenosis. Right ventricular failure will be there, ascites will be there, hepatitis. So whenever right ventricular failure is there, so ascites, hepatomegaly, and edema, systematic edema, peripheral edema will be there. Whenever left heart failure is there, so that will lead to the what? Any pulmonary edema will be there. Okay, pulmonary function will be affected. Okay, so these are the things, and we can hear the systolic thrill at the left sternal border. So this is very important. Systolic thrill, we can hear the left sternal border. So these were the things we have discussed. In next video we will see the cardiomyopathy. Okay, so these are the things. Okay, thank you everyone. Thank you. If you are new on my channel, please subscribe my channel. Thank you.